January 1st, 2020, you could wrap it up, put it in a bag, and you're not going to see that again for a very long, long time.
Hey, welcome to Unlatched Mind. Today, we're in mid-April here, 2020. We're going to get an update on COVID. Obviously, we're in the midst of a global pandemic, and today I'm lucky enough to have Dr. Adam Rosh, MD, on. Dr. Rosh he's a board-certified emergency medicine physician with a background in microbiology and public health. He also he's a founder and CEO of the Rosh Review, which is it's a nationally recognized medical company. It's an educational company serving physicians, medical students, physician's assistants, and nurse practitioners. Check it out at roshreview.com. But I had a great conversation with Dr. Rosh. I've seen a lot of his live Facebook feeds where he really gives a no BS update. He does a lot of Q&A on this pandemic. You know, we talked about where this pandemic started, why this one's different, why this virus is different, how it spreads, you know, what we could do to protect ourselves, and where it's going. And that's where things really got interesting. You know, we talked about, you know, what he thinks, you know, life's going to look like for us, in the States at least, and over the summer of 2020 is going to look quite different. Fall's going to look different. He thinks into next year, things are going to look quite different. We talked about, you know, how airline travel and cruises and public gatherings in general are not going to be what they were for quite a while. So anyway, had a great conversation, really enjoyed it. So with that, I give you Dr. Adam Rosh, MD. Well, Dr. Adam Rosh, I appreciate your time, and thanks so much for giving me some time this morning with zero notice. So
no problem. Good to be here, Vinny.
Yeah, thanks, man. So you know, we're here in mid-April. Obviously, this pandemic has been going on. No one's not aware of what's going on. But I just felt like it'd be good to have you or someone like you on to just kind of. This is not my normal topic, obviously, but my listeners know that. But I don't think we're in normal times. So, you know, and what I'd love to do is just kind of. And I think a lot of the stuff I've seen you already comment on, so it's going to be redundant for you. But as you know, you really can't get the real information out enough. So. I'm thinking if we just, you know, start with a little bit of what the hell is this thing, right? What do we know about it? And then maybe we dispel some myths that we hear. You know, we get stuff coming from the White House and it's the CDC, and it's like, oh man, how do you? And then you get the media that's just, you know, their whole world is based on kind of a little bit of everything has to be urgent breaking news. So there's a little bit of that driver, and then I'd love to get your take on where you think this is going. What does June look like? What does September look like? What's Christmas look like? You know, and then what's the new normal? So. With that, I mean, before we start, could you? Who are you? Who are you? I guess out there.
Absolutely, yeah. That's a good thing. Where's the information coming from here?
Yeah.
So, I'm a board certified emergency medicine physician. I went to medical school at Rutgers Medical School in New Jersey, in New Brunswick. I did my emergency medicine training at New York University, Bellevue Hospital, so in the heart of New York City, and from there. Went to Detroit Receiving Hospital, moved out to Michigan, and eventually ran the emergency medicine training program there. Now, my background is actually also in microbiology and public health. I studied that in undergrad and graduate school at the University of Wisconsin-Madison, and so I've always had a real deep interest in that. And so, right, COVID-19, this pandemic, kind of encompasses all of those aspects of my interests. And so disaster medicine has also been something I've been interested in. So I was a medical student back during 9/11. And then after that, people may not realize there was the anthrax scare. So we always prepared in training in NYU, Bellevue, which was in New York City. We went through training and did disaster medicine drills. And oftentimes, especially after 9/11, for example, there was a water main break, for example, and it was an entire city block blew up. Some people may remember that. It's if they're in the area, but it ended up killing a few people. But at the time, right, post 9/11, we treated everything as a potential chemical or biological attack, and that's seared in my mind as far as the potential disaster, managing potential disaster. Now, COVID-19 is a disaster in many, many ways. And, lots of people who understand microbiology and disease and contagion will tell you that what's going to bring down humans, what's going to bring down, if anything, our civilization, it's probably not going to be missiles and bombs. All right. As Bill Gates said, it's going to be microbes. And that's exactly where we find ourselves today. And it's really because the way these things are transmitted is they use the host to transmit, right? And so as humans become infected, the virus becomes more efficient at spreading in many ways. So COVID-19, the virus that causes it, SARS-CoV-2, first became really on the public radar here in the United States probably in January. There are definitely enough people who knew about it in January, and I started following it. I heard about it in China and really probably spent a lot of time in February digging into this thing because it was pretty clear. And to be, the disappointment is we should dive into this a little in how you manage pandemics, but the response at the highest levels in our country, removing the politics out of it, our country, our federal government is who's responsible for helping us manage an event like this. And we could dive into more of that. And what I just realized is you had asked me my background, and I kept going on.
No, that's good.
I'm gonna just pause right there and see where do you want to, what question do you have?
Yeah,
and,
sure.
I'll dive into that.
No, I appreciate that. So, and again, the organic conversation is what I'm after. So wherever it goes, it goes. No guidance. So just clarify too. The SARS, we keep hearing SARS-2. We hear COVID-19. Like one is the virus. One is the disease. Just for definition of terms.
Yeah, absolutely. So there's lots of coronaviruses out there, and in 2003, actually, there was an outbreak of SARS, right? Severe acute respiratory syndrome. Yep. And COVID-19 is caused by the virus SARS-CoV-2. So it's the SARS virus, coronavirus 2, right? The second one of SARS. And it causes COVID-19 or the coronavirus disease in 2019. It was first recognized.
Right.
Yeah.
Okay, gotcha. Yeah, you hear these things flying around, and it's like, I think setting a nice groundwork for terms is now. And how is this actually spread? Right, we hear airborne, but it's not technically airborne because you need particulate. Like, how is this thing spreading so efficiently?
Yeah. So initially, the idea was this was spread through droplets. Now, there's different size droplets, and droplets are generated, for example, with a cough or a sneeze, right? People have seen probably images or videos of how many droplets a human gives off during a cough or a sneeze, and droplets are able to suspend in midair, right? And so the virus is attached to this droplet, and it could kind of stay. So, for example, if I cough, there'll be a radius around me of a few feet of droplets, and those droplets remain suspended. All right. And that's a concerning type of transmissibility. Droplets is concerning. And there's more and more evidence, and I'm pretty confident that this goes beyond just droplet spread, right? This is aerosolized as well. Aerosolized means that if I'm speaking, the virus could actually leave my respiratory system, right? Because your respiratory system merges with, right, your mouth is part of your respiratory and your GI system, and so those particles could you could get exposure through there. And this is why the idea of non-N95 masks, that idea that that's going to limit or reduce or be kind of a solution, isn't necessarily accurate, right?
Yeah.
Because without an N95 mask, without a well-fitting mask, anything that's aerosolized will easily come out of the sides of those masks.
Right.
And N95 masks, they're specialized. They're not just cotton or material that's put together. They're actually a matrix material that allows us to breathe air while it filters out or prevents the passage of these virus particles. And it also comes with some come with a little respirator on it as well. And so those are really the important barriers for breathing that we need to be wearing. And obviously healthcare professionals, they have to have priority on this right now.
Right.
As they're caring for patients, because as we know, the number one place for spread of COVID-19, and I'm going to use COVID-19 as a stand-in for the SARS-CoV-2 virus. COVID-19 is going to spread mostly or predominantly in healthcare facilities. That's always the number one place in any type of epidemic or pandemic, and that's why it's so critical that healthcare providers first get priority on the masks. And then, and then the public is going to have to learn to wear masks. And this is going to be part of the new normal. And there's so much we could talk about in this new normal. I think it's important to understand what COVID-19 is and how we got here. And then the next part of this conversation in general needs to be, I'm talking the conversation of COVID-19 needs to be about, well, what does this next step look like? Because people don't realize that this is not a sprint. We are in a marathon here. And if you want to use a comparison of a baseball game, we're probably just in the first inning of this thing. And I know it feels like so much has been done and, we're a couple months into this, but these viruses, and I'll go into why, but they don't disappear, right? So there's only three pathways that we go, more or less three pathways. Number one, a vaccine is made, right? And it's effective. It has to be very effective. So if it only works for 40% of the time, then that's not going to be that great. But the thing with a vaccine is, even if a vaccine was discovered and created and today it was launched, we are talking months and months and months before anyone would ever get that vaccine. People don't realize the production ability is what's going to be a rate limiting factor here. Right, even though you have the vaccine, you need to produce it. And these vaccines are produced from chicken eggs, right? So that means you need 100 million, 200 million chicken eggs, and you have to wait for those, right? And then you have to incubate the virus and you have to grow it. So this is a long, long process, and the scalability of it is going to be extremely time consuming, and you need the facilities, right? We've never, ever had to produce a vaccine at this scale ever in such a short amount of time. And so while everyone has high hopes for a vaccine being the cure, it certainly is where we need to go. But we're months to even, over a year away from any real tangible impact of the vaccine.
And I would imagine there's plenty of human trials that have to happen to prove its safety, right? Even to start that timer that you were just speaking of, like, okay,
absolutely,
right? So so you got to add even more time before you can start trying to mass produce, right? I would imagine.
Well, in the normal situation, absolutely, these things need to go under pretty, intense scrutiny. I think, though, what will happen, like we'll see in certain drugs, you'll see like hydroxychloroquine was fast-tracked and approved by the FDA. The trials will be limited They won't probably have the same number of people. They won't go under the same duration. If you see some, and they'll continue, but they'll probably release the virus and keep the vaccine and keep tracking it. But yes, trials are happening right now. I mean, there's actually, from what I'm reading, right? I don't have firsthand. This is secondhand account, but there are trials, human trials going on with vaccines right now. So, so that's on one hand, that's one possible track, right? The other possible track is we reach a herd immunity, meaning, right, this virus isn't going away. This virus is endemic in the human population. And what I mean by that is, for example, in 2003, the SARS epidemic, by the SARS virus, it was able to infect people. It was mostly limited to China, and it ended up killing, I think, about 700 people. But it wasn't good at spreading from human to human, and so it eventually died out. Right? It was isolated and it died out. And so we really don't live with that virus right now. That is not the case for COVID-19. COVID-19 is approaching 2 million people, I think, internet throughout the world.
Yeah, according to COVID-19, whatever, bing.com/COVID, 1.6 million as of this morning. But unfortunately, you'll be probably spot on in a day or two.
That's right.
Unfortunately.
Yeah. So it will be there soon. Yeah. And so clearly, this virus has adapted to humans, and that's what viruses do, right? They could go from animals to humans, and then there's a host. So the virus will continue to spread as long as there is a host, and right now, humans being the host. Now, there are viruses like, let's say, Ebola. All right, it is unlikely that we will ever experience an Ebola pandemic. And the reason is because Ebola is a much better, for lack of better phrase here, it's a much better killer of humans. And so it actually burns its fuel, right? It runs out of fuel to keep living and keep spreading because it kills its host much faster than COVID-19. So COVID-19 is with us. We need to live with it. And until we reach about, herd immunity is, and this is actually a really important point for what the next phase is here. Herd immunity is based on the infectivity rate of the virus. So it's the R0 of the virus. And right now we believe it to be about 3. So for every person that gets infected, they're believed to infect another 3 people. And then those 3 people go on and infect another 3 people. So if you get, let's say, an R0 of 3, if you get to a population that is 70% infected, meaning they've recovered, and that means they have antibodies to the virus, and it means they're immune to the virus, then once you put those people out into the population, then the transmissibility of the virus becomes much, much lower. And what happens is those who have been infected actually serve as like lightning rods, right? They will slow down the spread of the virus. And this is why it's so critical that if we need to get this economy open again and get back out and get things running, it's so important that we are able to identify those individuals who have mounted an immune response to COVID-19 and by serological testing, and to get them back out. These people should be the ones working right now. These people should be the ones doing delivery, should be the ones in the factories, right? They get priority. Absolutely. I mean, that's the way you do this. And, there's people who talk about like immunity core, right? Like an immunity core. Yeah. And you have to be careful there, of course, right? Because there's ways that, discrimination could come from that as well, right? Should these people get, favored status? And so there's always secondary effects from this. But that is probably the most likely scenario in my mind that I see happening is this kind of this second pathway. Now, the third pathway is that the virus changes, the virus mutates. these viruses, especially coronaviruses, they change all the time. Same with influenza. It's the reason why we have to get an influenza vaccine every year because, right. And the bad years of influenza are usually due to things like antigenic drift or antigenic shift. And what that means is the DNA significantly changes. For example, it may infect a pig or a chicken, and during that time of infection, the DNA changes significant enough that it becomes much more virulent or much more its killing capacity increases or its transmissibility increases, and it could jump now from animal to human and wreak havoc on humans. And this is what is exactly what happened in 1918. And the 1918 influenza pandemic killed anywhere from 50 to 70, 80 million people back in 1918 and 1920, which on today's terms is hundreds of millions of people. Now, I don't think we're there. We're not, this COVID-19 is not as lethal as the influenza virus from 1918. So that's really the third pathway, is that if the virus changes or we see, we may see seasonality in the virus. And what that means is, just like influenza, there's a season. So it may come in the fall and the spring, and then, or the, fall and winter and kind of die off in the spring and summer. But right now, we're not really seeing seasonality with COVID-19. There's cases back in February. There were cases in the Southern Hemisphere. So Australia, New Zealand, South America, they all had cases. And so, right, it was their summer there. And as we move into summer here in the Northern Hemisphere, we're all hoping that maybe there's a slowdown due to the seasonality, but it's unclear right now.
And in this case, what would cause that seasonality? I mean, we know we get sick in the winter. And we also hear that you shouldn't go outside with your hair wet, all this stuff. Is it literally, it's literally got to be a temperature related. I mean, there's no other delta between seasons, or what happens there? Just.
Yeah. I think we want to think it's that simplistic, but I also think that there's other things like behaviors that you do, right? So for example, this is something where by example, I could try and explain it. So in the summer months, you have hand, foot, mouth disease in kids, right? Coxsackie virus. And that virus spreads really well. It's fecal oral. So it could spread from people's mouth, their saliva. And what do kids do in the summer? They jump around in a pool,
right,
and then they jump on one another, and they are doing that in the summer.
Yeah,
they're not doing that in the winter as much. So it's not that Coxsackie doesn't occur in the winter. Of course it does. It's not like influenza doesn't occur in the summer. Of course it does. It's that some behaviors that people engage in are much more common. It's same thing with polio virus. Now, obviously, we don't see polio here in the United States. But back in the 30s and 40s, and 50s, polio was spread in the summer months because it was fecal oral, and that's how kids kind of come together and play. So versus the winter months. So that's one aspect of seasonality, and can't really explain it sometimes we just can't explain it in some viruses. Maybe it's temperature related, maybe it's behavior related. But there's clearly peaks and valleys in the infections that we see in these viruses.
Perhaps in the winter we're all in the house where the windows are closed. When one person gets sick, they all do. In the summer, our windows are open more and we're out more. Maybe there's the distance thing that happens implicitly. Maybe. Absolutely. Yeah. That's interesting. Behavior more than just temperature. Yeah, because temperature never made sense, right? No one's like, the virus doesn't care if it's 42 or 87.
Right.
In terms of the big myths, I mean, you touched on a few already, right? The mask thing and the temperature, then the summer's going to kill everything. I mean, because there's some stuff online is like, I'm getting known to call this social media like a cesspool because while it's good for a lot of things, God, man, it can be a cesspool. But what are the biggest myths you think that should be just busted? People, we just need to just stop repeating.
Yeah. Well, here's the thing. I don't even maybe you could, tell me a few of them, because I don't even know what some of these myths are. I have an idea of what they are, and this is why. And this is, I think, an important point for people. Where I get my information from about this. And it was really nice back in February and early March, before this really hit media the way it is today, where there was only a handful of people that were talking about this in depth. And it was really wonderful conversation, whether it's Twitter or some news articles. Now, right, everyone's reporting on it, and every outlet just grabs the littlest piece of information and amplifies it, and it may not be accurate, right? So I could tell you where I get my information and where I suggest that you work on. It's not necessarily an outlet, it's who's giving it, right? So I when I'm doing research about pandemics and getting kind of the latest statistics, the CDC traditionally has been a very good resource. It kind of dropped the ball a little on COVID-19, and I think they could be doing a much better job, but I don't necessarily know if it's their fault or not in this case. And then I look for scientists and public health officials, and the best people on this are public health officials. So epidemiologists, my favorite go-to resource, the guy who has been on top of this since the very beginning back in January, is Michael Osterholm. You could look him up, Osterholm, Michael Osterholm. He runs the Center for Infectious Disease out of Minnesota. And he wrote a book in 2016 or 17 that it's unbelievable how it outlines pretty close to exactly what we're experiencing. So he studied epidemics and pandemics for decades. And it's people like that, right? It's people who have helped combat the Ebola outbreaks. It's people who have fought the influenza outbreaks. These are the people who understand what this is, right? I'm not going to ask an economist about the science and the spread of pandemics. But what I would ask an economist about, and which I have done, is tell me about how the economy suffered back in 1918 and 1920. Who were the cities that actually came out with the best economies, and which were the cities that suffered the most? And there's great articles that have been written on that as well. And for example, the cities that always took early and aggressive social distancing, stay-at-home measures, they are the ones who had the lowest mortalities and had the best economies when things, got a semblance of normality in the end. And so as far as getting the information, stick with scientists when it's a scientific problem. All right.
Right.
And I can't I don't listen to anything that I could get on my cable networks, in a sense.
Right.
Because it's second and third hand knowledge. And I think the time I spend on one good article by Michael Osterholm or one interview by Michael Osterholm, he provides answers to everything I need to know at that moment, with a very objective explanation.
Right. And their agenda would be strictly the science, which is what you want. They don't have an agenda, and some of these agendas are pure, right? Where, and that's why I think we're all chanting for Dr. Fauci to speak and let Trump get out of the way and let him talk. But even then, you're right. He's sitting there next to the commander in chief, and I'm sure he has other forces behind on him. In other words, the economy. There's things that are not just science that they are. They have forces at play that guide every word they say. So you're right. Yeah, everyone has an agenda, and and to the commander in chief's, to be him, he also has to keep the economy alive, so it's like, where's that balance, right? There is other forces out there besides just speaking at the the microbiology level. But you're right. If you want to know about this disease, go to the scientists. I mean, absolutely no one will push back there.
Yeah. And I just got to add to that because, when you study the response, right. And I keep going back to 1918 and 1920. And the reason why is because it's the biggest, most deadliest pandemic that the modern humanity has experienced, right? The Black Plague was probably a little worse. It was like, 12 or 1300s, right. I think. So when we study 1918, 1920, what we find out is that the most important aspect of what a government or the leaders could do to help the citizens, to help the country and the world deal with the pandemic, is, first of all, you got to have robust and strong leadership. And what does that mean? That means being transparent. Means being honest. And that means putting a plan together. Now, doesn't matter what your political affiliations are here. What's so obvious, what was so clear, is that is not what we're getting from the people we need here. Okay. So when we get daily press conferences, those need to be done initially. There needs to be one leader who understands pandemics and is laying out a plan for everyone. Right. And we are not getting that. Instead, we're getting, political theater. And that ultimately is going to lead to a prolongation of this pandemic. It's going to lead to increased mortality that was unnecessary here. Now, as the only thing I could say that is moving in the right direction, and I say this very cautiously, is that we absolutely cannot maintain a shelter in place for a year. All right. There's right. What we're doing now needed to be done so that we could flatten this curve. And if you want to talk about what that means, I'm happy to do that. But for now, we had to flatten the curve at this moment. Okay. And the next phase, though, is we need to get back out and get things going. But they are not mutually exclusive. And when you have a leader who simply states, we need to end the stay-at-home order and get back out and get back to business, right?
Yeah.
That's irresponsible and it's misguided because you can't just do that.
Right,
you have to be able to manage both at the same time. And as Michael Osterholm would say, you need to thread the needle hole here, right? So I do believe that our leaders in, for example, I'm in the state of Michigan, and I think they did a really great job with early and aggressive action, but we also now need to start transitioning to getting things open again. And what I talked about earlier with, how do you do that? You do that through serological testing. You do it with widespread diagnostic testing. You do it with surveillance, right? There's lots of, and no one's talking about this. This is right. Yeah. We're going to be dealing with this for months and months and months. 2020 is going to look like what you see now, masks 5 feet or 6 feet apart. 2021 is likely going to look like this as well. So how do we adapt to that new normal? How do we get people back out getting coffee at Starbucks, right? Being able to go to, Home Depot and buying garden, going to your local garden store, getting a slice of pizza. How do we get people back doing that? And that is a conversation. So I do credit that there is a push for that, but it cannot be done in a silo. It needs to be done with coordinated efforts on implementing the proper systems. And it's really almost all about, it's testing and support.
Well, the testing thing was another top. So because, I was thinking, I'm thinking along the same lines, what you just laid out is, we're not going to flip a switch here and have everyone just go
That's
back.
right.
No, it doesn't make any sense. Just if you know the beer,
Right.
it doesn't make sense that would be the case. Otherwise, it just doesn't make sense. Period. But in terms of, I always think. I'm thinking in my head, if I could take a test right now and my mom wants to come see the grandkids, she's out of state. Okay, like say she was here, to keep it simple. If she could take a quick test, get an answer in 5 minutes, we could take a test, get an answer in 5 minutes. Then all right, let's hug and let you play with the grandkids. Now that might be, pie in the sky thinking, but is something like that potential? And was that a year away, 6 months away, or?
We tout ourselves as being the greatest country in the world and our most technologically advanced country, and capable of doing anything. Well, let's see it, right? Yeah. Like this is what we need to be doing. We needed, as people would describe, we needed a Manhattan Project for COVID-19, and we do not have
like that. Yeah.
We needed the best minds to come together to provide leadership. And it's not too late. Those things could still happen. Remember, this is the first inning of a 9-inning game. We have a long way to go. And what I would love to see our leadership doing is putting that together, right? We're spending a $2 trillion stimulus right now. Well, if you look at the cost of the actual Manhattan Project, right, it was far less than that, even in today's dollars. And so we are capable of doing big thinking, and that's what we should be doing. So, we need both diagnostic testing and we need serological testing. So the diagnostic testing would be, are you infected right now? And the serological testing is, were you infected and now you're immune? And so let's just say in the scenario you gave, you wanted to visit someone such as a parent or a friend, and they know that they are immune. Then certainly they could come over and spend time with you. Not only that, they could go out into the stores and bring you stuff and get into the workplace. Now, there's one little point of caution here, just because, where if this is going to be on the record, I want to make sure that that we at least provide some other evidence. So as of today, and today's right now we're in April of 2020, there is some evidence coming out of South Korea, that people who have tested positive for COVID-19 diagnostic testing, who have then had a negative COVID-19 test and have serological immunity, are now showing retesting as positive for COVID-19 again. And this is very concerning. And there's a handful of cases like this out of South Korea and China. Very, very concerning here. And the thought behind it is that possibly this may be due to a reactivation, right? So viruses, for example, the best example I have in COVID-19 isn't exactly this, but for the sake of this example, let's think of it this way. So the herpes simplex virus, viruses are just pieces of DNA or RNA. The herpes virus will invade one of our cells, and it will take its own DNA. It will splice our human DNA, a segment of it, and then it will insert its own DNA into our DNA. And the only reason why it does that is because it uses our machinery to reproduce, right? And now it's in our DNA, and it will never go away until that person dies, right? And so that is why you could get a cold sore, and in 3 years it goes away, and then 3 years later you get another cold sore. And that's because the herpes virus is actually, it's not that you got a reinfection, it's because there was some stressor in your life, whether things like UV light will do it, where it will activate that chunk of DNA and it will reproduce, and then you see the consequences, the cold sore. So COVID-19, it's unclear what it's doing, but one possibility is that it is reactivating, that maybe there are pieces of DNA still in our system that didn't get killed. Maybe it's integrating into a genome. We don't know enough yet. So that's some concerning news.
That is scary. Yeah. You're not full of good news here today, sir. No, no. But I want the real scoop. This is good. People need to hear it. I was always concerned with that. I don't know if this is a reality, but we all stay at home. Now, the reactivation part you just talked about, that's another next level kind of concerning. But even without that reality, do you see a possibility of a second wave? In other words, we flatten the curve. Everyone's kind of staying at home, and I think the main point of that is to keep the healthcare facilities and personnel from being just bum rushed, more for lack of a better term, right? I mean, that's the main right. Now, if everyone stays home, and then we, like you said, we can't just flip a switch and everyone go back to their normal daily routines, because at that point there would certainly be another spike, right? If that curve starts flattening, I would imagine it would just maybe not to the same steepness, because for various reasons. But do you think once this curve starts flattening, it should stay flat, or is there things we could do to screw this up again?
Yeah. Well, you leave it to humans, right? We'll find a way. On one hand, we'll find a way to solve it, but we create the problems that we solve. Right. So the flattening of the curve, and I think it's important just to get that understood. When you have large number of cases that we're seeing right now in various cities across the world, there's a capacity that our hospitals could manage. And so there's flattening the curve and there's raising the line. And I'll explain the difference between the two. So if take just a single hospital. Single hospital has 20 ICU beds. And in one day, you have 40 COVID-19 patients that require those beds. So right off the bat, the first 20 get the beds, and then the other 20 can't get treatment. Okay. In addition to those 40 patients, there's 20 other patients that needed the ICU for totally unrelated things. Maybe there was a car accident. Maybe there was complications from appendicitis, whatever it may be. Right. Now, those people can't get a hospital bed. And so while for the sake of this example, everyone would have who got into the ICU been managed appropriately, gotten great treatment and care, and actually recovered. But when 30 or 40 people can't get when there's 30 or 40 more people than the 20 beds, those people are going to have unnecessary morbidity and mortality, meaning they would have been treated, but now they can't. Right. Not because, the virus is necessarily going to do anything to them. Or, I mean, it will, but let's say those people who wouldn't die with care, those people now die. Yeah. And so we have excess deaths. And it's really important during the early phase of pandemics, when everything starts exponentially growing, to be able to flatten that curve. And that doesn't mean we're reducing the number of infections. It just means we're spreading out the number of infections. Now, that's right. The other part of this is we could raise the line. And what does that mean? That means we could improve the capacity of our hospitals. And that's what you see happening, where hospitals are being converted, or warehouse, large facilities, gyms, churches, or whatever it may be. Any open space will be converted to hospitals. There's the ship that came in New York City. And that's what's referred to as raising the line, because now it increases the capacity, right? And that curve, right, gets closer and closer to the top of that curve. Right. Okay. Now, with all pandemics, or with most pandemics, and there's some variability with these, but there's always a second wave. There's usually always a third wave. And that's exactly what you alluded to, right? So we get past this first wave, and here's what's really interesting. People will start saying, you'll start hearing this, well, there's only, these many people got infected, or these many deaths occurred, or, oh, look, right, I still see people posting stuff saying 50 million people died from influenza and only, 20 million have died from COVID. And my response, there's so many responses to it, but my first response is, well, when's the last time your entire state stayed home or wore masks during an influenza outbreak, right? So the reasons why we're able to see lower mortality right now is because we've had significant behavioral changes.
Right.
And without those, we would already be beyond 50 million people easily dead in the United States. Easily. Okay. So the paradox of pandemics is that if you manage them right, when it's over, everyone says, look, we didn't have to do any of those things. It wasn't as bad as we thought it was going to be. And that's the paradox there. All right. And that's what will happen. You will have short-term episodes of that, right? People are starting to say now, well, my town's not affected, or, there's not that many people, dying in certain areas, right? Obviously there's extreme devastation happening in many cities around the country. So once people start going outside, the virus hasn't disappeared and people will start getting infected again. It's inevitable. All right. And this is why, this is a long-term marathon and this is the first inning. And we need to learn how to manage how we're going to live with these future spikes.
Yeah. And I think, and I saw one of the interviews you had done, I think it's a very, very good point. I want to reiterate it here, being healthy. I think you had said it and you said it so succinctly, just generally being as fit as you can possibly be. I think these are almost your words, right? It helps you pretty much your success rate through anything life throws at you. So why not take this opportunity to get in the healthiest that you've ever been, right? I mean, lose that 20 pounds, right? If you're a diabetic, obviously you got issues you got to deal with there, but losing weight helps everything, right? We know it. Put down the sugar, put down the crap. I mean, I think people are walking a lot more. I mean, my neighborhood's full of people walking that I've almost never seen before. I'm pretty lucky. I've always enjoyed exercise. So I try to even up it a little bit more, but I think folks should realize being as healthy as possible, try to quit smoking now, right? Maybe use this as an opportunity. That certainly will help, right? Because eventually I almost feel like, to your point, eventually I almost feel like most of us will pretty much get this. So let it just be like you got a cold, but your anatomy is so, you're quote unquote so fit and so ready for things, let your body can handle it much better. I mean, I think that's something we would also be thinking of as well.
Yeah, everything there is extremely important and valid. And we talk about, people are worried about, am I at risk? Who, if I have this condition or that condition, they're called comorbidities or risk factors. I have high blood pressure, I have kidney disease, heart disease, lung disease. There are specific things that put you at increased risk, right? We're seeing, in China, for example, and here in the United States, obesity and smoking, for example, and smoking in particular. And a lot of that is probably because of right, when you get respiratory failure, your fluids fill with lungs, it's just very hard to maintain that exhalation phase of breathing for patients who can't do it on themselves. So when they're mechanically ventilated. But I always say, right, there is nothing protective about not being healthy. Right. So, right, if I have high blood pressure or if I'm a smoker, that doesn't protect you from any illness, right? And so, yes, of course, if you are a smoker, of course, if you have high blood pressure, you're at increased risk for not just COVID-19, you're at increased risk of every ailment out there, right? Because your body doesn't have the same reserves as someone who doesn't smoke or someone who is not obese. And, I was trying to think about, there is one disease that I could think of that we're taught in medical school that is protective. So like, for example, tobacco smoking is protective in a certain type of inflammatory bowel syndrome from a cancer. It's kind of this weird, who knows if it's really tobacco smoke, but that's what we're taught. But the takeaway here is, and I could tell you what I decided.
At least 10% of the people
that
are going to hear that and say, see, smoking's good for you. Dr. Rosh
well,
said
we always struggle with that one. Yeah. But those people may not die of colon cancer, but they'll die of lung cancer. You know,
and they're just silly. But.
So, unfortunately. So, I think you're right. And people are using this time to, now that it's fall, at least in spring in the United States, and it's been decent, the weather, at least in some regions, getting outside, walking, riding their bike. Right. And that's very important. But I'm thinking myself, like, what should I be doing? I'm a pretty, I'm not overweight. I'm not thin. If you look at my body mass index, it's high, not in the obese range, but I'm a big bone structured guy. I'm 6 foot, 200 and about 18 pounds. And I was thinking to myself, maybe just so what you said, it's almost inevitable. That contradicts itself, but it is, we're approaching 100%. Yeah. When it says, will I be infected by the virus that causes COVID-19? And if that's true, then how can we prepare ourselves for it? And so I made a decision. I'm like, I am going to make sure that I am nowhere near obese. I am going to start focusing on my cardiovascular system. I am going to make sure that I have reserve, right? Pulmonary reserve, cardiovascular reserve. Because if I am one of those people who gets infected and has a bad response, then I want, right? Because right now there's no great medication or treatment. And we should touch on that, but there's nothing great out there. And we know that some of the reasons that people, what we say in medicine, go down the tubes, is from this cytokine storm. It's your own body's response, which is causing intense inflammation and edema or fluid within the lungs. And, if you could kind of wait it out, right? If you could not wait it out, but if you could survive it and stay alive, that's your chance in those severe cases. And they look at intubated patients. I just got this data from the New York City hospitals. Something like, if you're intubated, they're intubated patients, so they have a breathing tube. 25% died, 25% lived, and the other 50%, it was a prolonged intubation. So something like 7 or 10 days worth. And then of those patients, a certain percent lived and a certain percent died. But any prolonged intubation is going to be lots of complications come with that.
Yeah. So if you're someone that that walks up one flight of stairs and you're excessively winded, and unless you have an actual medical condition, I think you think about it. You should not be winded after one flight of stairs. I'm sorry. I tend to be a hard ass to people because I'm very sure and convinced most of our ailments are behavior related. There's plenty of medical reasons why certain folks have things, not including them, but we have some bad behaviors and we all make excuses. And I think we should use this as an opportunity to be ready to get the virus. Frankly, just the new norm. I think that's what the takeaway for me is we're going to probably get it. So don't try to, at some point we want to try to, I think, step into a new mentality, a new way of thinking of like, I got to avoid getting this. I can't touch that. How about being ready to get it and having it not really be that threatening to your life? I think that's eventually a better way to look at this whole thing. So where do you think, and we can kind of close with this, but what do you think June looks like? What do you think September, Christmas time? We're sitting around Christmas dinner or whatever you celebrate dinner in December, and what does it look like?
Yeah, so I can't predict as far as, specificity of this month or that month. I could tell you that based on certain types of behaviors, what those outcomes will look like. So if my guess is in, the end of April, beginning of May, people are going to start, these shelter in places are going to stop. And, we could do a better job with these shelter in places. There are some places that have such low infection rates that it doesn't make sense really to keep people inside. But we would need some type of testing or surveillance program to support that, right? To get them back out. So what does this look like? I could tell you what it's not going to look like. It's not going to look like January 1st, 2020. January 1st, 2020, you could wrap it up, put it in a bag, and you're not going to see that again for a very long, long time. Our new normal, and I actually think it's really important. What can we be doing right now mentally is adjusting to this new normal. It's, we go through denial, and now eventually you got to get to acceptance. And once you get to acceptance, you got to start thinking about, all right, how do I make my adjustments and how do I make the best of the situation, right? There's lots of opportunities that come out of this. I mean, right here, you and I, right, we're on this podcast, we're recording right now, and it's a wonderful thing that we could do in the middle of a pandemic. And lots of people could go out and start talking to other people and recording it. And so there's a lot that could happen, a lot of opportunity. So first you have to accept that this is not going away tomorrow. There's no all clear signal that we could go outside and, go back and go to a concert. That's done for a very, very long time. So, right, group gatherings are not going to be the same anymore. And this is kind of as I describe what the future holds. This is what I mean by that. So if I want to get a coffee at Starbucks, hopefully in May, I will be able to do that. The future that I envision is there will be someone at the door when you walk in to every place of commerce. They will do a quick temperature scan with a device that they could stand, they're wearing a mask and, they could be 3 feet away. They could do a quick temperature. If you have a fever, you will not be allowed in the store. It's harsh, but that's what not the really. Future is. I think you're not going to be allowed in the store. If you are allowed, if you meet that first criteria, you're going to come in. There is going to be almost like stations of where you could stand. So people will obviously need to be 6 feet apart in line. The workers behind the counter will have stations that they're working in as opposed to going back and forth. People will be contained in certain areas. And hopefully more and more transactions will be electronic so that you don't have to hand money, right? You could use, let's say, your iPhone or device and just do a cashless or cardless transaction. I see flying to be very different on airplanes. I see the good part of this is I do see middle seats being empty.
There we go. Some positive here. Nice.
That's right. So I believe maybe every other seat, every other row type of flying. And these are, if airlines, if I'm going to fly on a plane, I'm not flying on a packed plane right now, right? I'm not doing that for a year. I'm not doing that for 2 years. So if anyone wants to, or if I knew I was immune, right, and that's where serologic testing comes in, then I would. But as long as I don't know, I'm not taking the chances, right? So flying is going to look different. Ball games, football games. I think there's going to be a push to get those going, and I think they will. All the players will be tested. Temperatures will be taken. There won't be hand slapping. People will be sitting, like, let's say, in the dugout or a sideline. They'll be spaced 5 feet apart, 6 feet apart. I think the stands will mimic what I talked about on airplanes. Right? Every 3 seats will be a person. So that's what that looks like. this is the light. This is what the world is going to look like in the next year. There's no way around it, because I can't imagine if I were a 65. I mean, do the scenarios. If I'm a 65-year-old, 70-year-old teacher, and I want to go to my math class in the fall, in September, and I don't know whether I'm immune or not, and I don't know whether my students are immune or not. Am I going to teach a class of 30 kids who are coughing, sneezing, snot, right? Because the same old cold viruses are still out there.
Right.
I can't see that happening. And so who's teaching these classes?
Yeah.
Right. How does school get back? Who's going to put themselves at risk? Because if it's your school and that first 70-year-old teacher dies, what are the other 60 and 50-year-old teachers going to do after that? And this is the reality that we're going to be in. And so something needs to get done. A system needs to be put in place. Kids are going to have their temperatures taken going into school, and hopefully we get rapid testing. And that's what we need. The world will look different, just like after 9/11. Where, the security lines changed, the background checks changed, whatever applications changed after 2008 for mortgage loans. This is just on a universal level. All of this is going to be changing. And the sooner businesses could make this change, right? If you're a business owner out there, or you're an educator or a scientist or whatever it is you're doing in your place of work, the sooner you could adapt, the faster and more effective and better situation you're going to be in, because this is not going away. And but that doesn't mean things have to come to a halt. It means just have to use our ingenuity, use our creativity, and be smart about our decisions.
Yeah, I imagine it's going to be rocky, because I could just imagine the lobbying against some of these things, right? The amount of revenue lost by the airlines and by the Major League Baseball, all these things, all these bottom lines that were at X prior to this are going to be at whatever X divided by 2 or some ridiculous, and is going to be lobbying against it, and so I hope we all do the right thing as humans, because what's interesting is the whole thing is you take a step back, and I just want to leave people with this. Use this opportunity to do something real good. Start that company. Oh, business is bad. Again, those are excuses. Everything's online. Figure it out. Just figure it out. Wake up earlier. Exercise. Talk to your friends more. Talk to your family more. Call your dad. Call your mom. Just buy that video camera. Buy that little webcam and Skype with your mom. Zoom with your dad. Whatever. Teach them how to do it. It's going to be frustrating. They're not going to know how to do it, but you can work them through. Do the stuff that we're all so busy to do prior. I say be busier, but just refocus a little bit. I hear a lot of people on board and all these jokes going on Facebook. Who's bored? Who's doing nothing? What are you talking about? Why? It's not the 18th, 19th century, whatever, when you're just sitting there in a house with nothing. You have the internet. You could literally just consume, share, start a podcast. Read a book, write a book. What? It blows my mind. Boredom is this thing that I have more work now than I've ever have, and I think most of the people that I surround myself with are in the same boat. So it's just silly, the boredom thing. But and one I'll leave it with this. None of the crap I think that divides us as humans. If you notice, none of this matters, right? It went from China to this country to Italy to here. Right. We're all the great equalizer, right? So all these silly little things that we divide ourselves with across the borders and stuff, it's oh man, can we get over it? Can we get over it? We can all die together, just like that. And let's use this as an example to prove that. Yeah, absolutely. As Martin Luther King said, he said something along the lines of, we all came on different ships, but we're all in the same boat now. He's a genius for a reason. Well, Dr. Rosh, I appreciate your time. I really do. I think this was super informative. I learned a ton. I know the listeners will as well. So I'm going to fast track getting this out just because of the timing. Usually it takes a week or two before I can, edit and release something, but I'm going to try to get it out in the next few days. So, man, thank you so much. This was awesome. Yeah, good talking to you, Vinny. Thank you, Adam. Appreciate it. Yeah, you bet. And we're done. Thanks for listening. We'll catch you next time. Be safe out there. See ya.